Dr. James Harrison's postdoctoral researcher with the Mycobacterial Research Group at Aston University. He has an interest in mycobacterial physiology and cell wall biochemistry, and his current research revolves around the repurposing of existing antimicrobials to combat mycobacterial infections. Excellent.
Hello, everyone. I'm here to talk about the in vitro efficacy of relebactam versus avibactam against the Mycobacterium abscessus complex. So what is Mycobacterium abscessus? It's an environmental, rapidly growing non-tuberculous mycobacteria, which is an opportunistic human pathogen and is often found in sources of soil and water, such as your taps and your shower heads at home. It's capable of causing both pulmonary and skin and soft tissue infections, and people of particular susceptibility are those with underlying respiratory conditions such as bronchiectasis and cystic fibrosis. And part of the main issue is that it's a very long, prolonged treatment regime that often has very low patient compliance, because it consists of a first phase, which is about a month of amikacin, tigecycline, imipenem, and a macrolide if the isolate is susceptible. And then this goes on to a continuous phase of clofazimine, linezolid, minocycline, amikacin, and moxifloxacin or cotrimoxazole, depending on what the isolate is susceptible to. And this continuous phase lasts for about 12 months. So as you can understand, patients get very exhausted with the regime. Also, there is about a 70% failure rate. So even if you persist with the drug regime, the chances of survival are very, very low indeed. So as you can understand, we really need better treatments for this infection. And it's exacerbated by the existence of multiple subspecies which have different antibiotic phenotypes. M. abscessus has multiple drug-resistant mechanisms, and one of interest to us is an endogenous class A beta-lactamase, which we call BLAMAB, which provides resistance to beta-lactam antibiotics. Now, BLAMAB has around a 45% identity to BLAS-C from Mycobacterium tuberculosis, and BLAS-C can be inhibited by clavulanic acid, sort of the classical beta-lactamase inhibitor. However, BLAMAB, because it's quite different, is not inhibited by clavulanic acid. However, we have now seen that the newer non-beta-lactam based beta-lactamase inhibitors do inhibit BLAMAB. So these are relebactam and avibactam, as you can see here on the left and right. These are available commercially at a 2-to-1 ratio with imipenem for relebactam and a 4-to-1 ratio with ceftazidime for avibactam. Now, these drugs are often used primarily to treat gram-negative intra-abdominal and urinary tract infections, and can also be used for hospital-acquired pneumonia, but they have not yet been used for a Mycobacterium abscessus infection. So we don't know if these commercially available ratios are actually the right ratios that we should be using. So we thought we'd look into it, and we tested ratios of 4-to-1, 2-to-1, 1-to-1, and 1-to-2 of drug to inhibitor against Mycobacterium abscessus NCTC. And what we saw was that for imipenem relebactam, all ratios that we tested were effective at inhibiting the bacteria in liquid media. However, when we looked at ceftazidime avibactam, it was apparent that the ceftazidime, even with the inhibition by avibactam, had no effect on the growth of the M. abscessus. So what we then excuse me, what we then concluded was that all the ratios of imipenem relebactam were inhibitory. However, when we looked at whether they were bactericidal, we only saw bactericidal activity above a 2-to-1 drug to inhibitor ratio. And because ceftazidime seems to have no effect, we can conclude that the commercial ratios are actually the appropriate ratios to use, certainly going forward for the next set of experiments at least. So we decided, what if we added a third drug to this compound? Could we make these commercial ratio combinations better? So we did some preliminary work and then decided to try these combinations, with meropenem. So to begin with, we looked at imipenem relebactam with meropenem, and there's a lot of graphs here. So graph A is Mycobacterium abscessus NCTC. B is a clinical isolate that we've seen that we've identified as subspecies abscessus. C is a clinical isolate we've identified as subspecies Bollettii, and D is a clinical isolate that we've identified as subspecies Massiliense. And this will be the same for the next few set of graphs. What we've identified here is that with 1 microgram of meropenem, we can push the effective concentration of imipenem relebactam to 0.75 microgram per mil imipenem, 0.375 microgram per mil relebactam. And at the end of these graphs, you can see regrowth at those concentrations. So at that concentration, the bacteria are dead. When you remove the imipenem relebactam, they're alive, and when you remove the meropenem, they're alive. So this was consistent across each subspecies, which is excellent news. We then looked at ceftazidime avibactam with meropenem. So here we required a little bit more meropenem, but slightly less avibactam than we did relebactam. But because of the 4:1 ratio, we have quite a high concentration of ceftazidime in relation to imipenem. So it's 0.75 microgram per mil ceftazidime, 0.1875 microgram per mil avibactam, and 2 microgram per mil meropenem. But as you may see, for subspecies Massiliense in the bottom right corner, it requires a little more meropenem. Now, this is because of the difference in antimicrobial susceptibilities that I mentioned earlier. Sometimes the subspecies Massiliense has a higher drug tolerance than other subspecies, which we won't go into, but we also looked at a non-commercial ratio of imipenem avibactam just to see what would happen. So we added imipenem avibactam with meropenem, which actually gave us very, very low concentrations. At 0.375 microgram per mil imipenem, 0.1875 microgram per mil avibactam, and 0.5 microgram per mil meropenem, we had cell death. And this was consistent across each subspecies again, except for subspecies Massiliense, which required a little bit more imipenem. So excellent news, we can kill each subspecies. However, what does this all mean? So all 3 combinations were effective against abscessus complex. The imipenem avibactam meropenem combination yielded the lowest bactericidal concentration, sorry. However, that is a non-commercial ratio. So it's a good result for the future, perhaps, but right now it's not going to help us much for those patients that are currently dying. We also identified earlier on that ceftazidime is really ineffective against M. abscessus. So the ceftazidime, avibactam, and meropenem combination isn't really much use to us. However, imipenem is already a frontline treatment. And the addition of relebactam and meropenem on top at very low concentrations could rapidly be introduced into the clinic, and then would increase the patient quality of life because you would need less concentration of drug, and you could also potentially increase the outcome of the treatment and therefore increase the sterility of the M. abscessus infections. These concentrations are in line with the predicted estimated epithelial lining fluid concentrations that are achievable in the lung. These are around 5 microgram per mil for carbapenems. So we are well within that therapeutic range with these concentrations. So I think it is a really appropriate, fast opportunity for deployment into the clinic with these combinations. And I'd just like to finish off by thanking my supervisor, Dr. Jonathan Cox, our collaborators, Dr. Maya Desai, and everyone in the lab in MB327 and our funders. So thank you very much.